Welcome to our seminar webinar series for the awareness building on DRG and USC. This presentation is Model 2, the story of Thai DRG development. This is the second of the 5 modules of DRG e-learning designed for audience of country team considering to implement DRG as a payment mechanism within the universal coverage framework. After you complete these webinars of core and specific module for and a self-assessment for evaluating comprehension, you probably will be able to utilize the knowledge on DRG to design strategy, the roadmap to adopt or to adapt the application of DRG into your country USC framework according to your role and responsibility, and to step up your advanced knowledge and experience on DRG by planning further learning to fit with the country appropriate USC status in the country. This module will explain about the essential assumption for success. That's the situation before 1993, 7 years of the research and development from 1993 to 2001, and 20 years of learning, 2002 and up to 2022. And shortening the path for the low and middle income countries. For the essential assumption for success of the Thai story, it's related to the context of the healthcare reform and DRG research and the team building. In the first module, I showed this slide before. It's about the health insurance model. And before 1983, we have different schemes, fragmented scheme, and not covered the whole population of Thailand. And we are thinking of, if we have universal coverage, either by the beverage model, that's a tax finance, or the Bismarck model, or the compulsory insurance, we should provide protection to the population with the payment mechanism. And one of the payment mechanism is the DRG to cover the inpatient care. Why DRG? It is because we have experience with the fee-for-service payment, and fee-for-service, as we already know, it's too expensive. And in 1990, that's before 1983, we have capitation payment for the compulsory insurance, that's the Social Security scheme, which started in 1983. And it is the inclusive capitation, that means cover the outpatient and inpatient services. And this capitation payment proved to be the problem of underservicing. As the alternative, then I have looked through the DRG. It's the publication in the medical care by Robert Fetter in 1990. That diagnosis related group, it's a measurement of hospital product. The patients that classify into the same DRG will predict the length of stay and the resource use. This is the definition that we had focused on the research on the DRG. How can it be implemented? How can we understand more, and how can it be implemented in Thailand? This is a historical background of Thailand. The graph is on the gross national income per capita. It's the indicator of the level of development, economic development since 1970s. And within the diagram in 1975, we started several medical welfare schemes. And in 1980, the Civil Servants Medical Benefit Scheme had revised the regulations of how to pay to the hospital, which is mostly on the fee-for-service. And in Thailand, we experiment the voluntary health card in 1983. As I mentioned earlier, the Social Security Scheme, which is the first successful attempt to enforce in 1990. The fighter for this compulsory insurance, he said he had fought for 26 years before it became a law in Thailand. And as soon as we passed the law in 1990, we first introduced the contractual model of the capitation. We claim to be very successful in cost containment, and we contract public and private hospitals to provide services for the insured worker. Then we had the history of the healthcare financing study in Thailand. The first around 1983. We have the financing studies that tell us the Thai health system was heavily depend on the out-of-pocket payment, and we have several workshops and movement that want to achieve universal health coverage. From the experience of capitation that come with the Social Security Scheme, we start why we have the vision of universal health coverage. Should we not stay only with the capitation because it's encouraged under service, as I said, and there is alternative. The publication since 1980 of DRG struck me to carry out the research since 1993, and from this we can accumulate the knowledge and had allies. That means the team to move forward, that after the economic crisis in 1997, even though we faced with the crisis, and at this time of 2001, it's the good opportunity to establish the universal coverage policy in Thailand. And in the at that the proposal, what should we do with the financing arrangement? It's from the research we can put the DRG into the to the guideline that universal coverage in Thailand should use capitation and DRG. So the history of since 1993, the Health System Research Institute, which celebrate 30 years anniversary just this year. It was the organization that started the investment in the DRG research. With the at the time we since DRG is as explained that we should study the DRG for the whole spectrum of the acute inpatient, but it seems too big. The first research we start with the accident and emergency and try to understand how to gather the information about the patients who had the road traffic accident. Since because of that time, 1990, around 1992, we passed the law of the Road Traffic Accident Protection Act. But in the act, it's mentioned that we use the fee-for-service payment. So this is the beginning of the first research. And the first research was financed by the Health System Research Institute. We start with a paper form collecting clinical data and charge data from public and private hospitals in 10 provinces. Select the 10 provinces with the high number of road traffic accident. And we finished the first version of DRG, Thai DRG on accident and emergency with about 100 group of to cover this disease. And 2 years afterwards, the research expand to cover all the diseases. Again, still with the paper base. And this time, we end up with the all of the condition. One year later, we test the DRG grouper with the electronic data from the public hospital. Since the hospital in Thailand already implemented the computer to service the medical record service, so that we asked the hospital to send the data. In 1999, because we have additional budget to pay for the low-income class scheme. So we were successful in proposing the setting aside about what 100 million, a certain amount of budget that's pay extra for the low-income class scheme, and we try with the hospital information that's sent into the diskette at that time, 3 inches diskette, just sent to the hospital, to the ministry, and analyze with the first version of groupers for the relative rates higher than 3, get reimbursed extra for that. Then it's approved to the hospital that hospital information can earn the money back to the hospital because of proof that the data in the computer, they had service for the low-income class patients, and the patients is severe enough. So from the looking at the hospital data in the electronic form, we found out that we had not implemented the standard in many fields, in many data fields, except we had the ICD standard for the diagnosis. Then this was the year that we launched the standard dataset for hospital to export clinical data if we were to use DRG for reimbursement. And after the government had the policy, the universal coverage policy, DRG version 2 was ready for use for the payment of the universal coverage scheme at that time. The first year of the universal coverage in Thailand, it was an experiment. The province can choose to allocate budget inclusive capitation. That means outpatient and inpatient include. Did not use the DRG, but about half of the provinces, more than 30 provinces, use the DRG to allocate the inpatient budget. So it's a situation that we had the experience. So this is the first version of standard datasets for the DRG at that time. And in the document of the HSRI, or the Health System Research Institute, this is a schematic layout of the, if we had to proceed on the universal health coverage, we should have a structure like this of the National Universal Coverage Fund, and later we have area purchaser board, and split the budget into different basket. Outpatient funds allocate on the capitation basis, but it's a risk-adjusted capitation to the contractor unit for primary care. For the inpatient fund, use the DRG since the HSRI had invested on the DRG research for 7 years. So before the universal coverage, we already have the DRG for 2 versions, version 1 and version 2, and around 500 groups that based on the US DRG. So some of the situations that force us to be successful, since Thailand implemented ICD-10 since 1993, and at that time, no DRG groupers used ICD-10. Then we have to rely on ourselves. And the hospital in Thailand had, before the universal coverage, even public hospital charge the patient. And when we use the computer, the hospital pay attention to the billing system. So the data from the bill is already in the computer. So that's the good data source. And several hospitals had the hospital cost studies, and it was the beginning of the IT system of the hospital. Hospital had computer, had used it, had somewhat entered the data, patient's data, medical record, patient summaries, or the dispensing data in the computer, but had not used for the central purpose that it's used at the hospital level only. DRG was the first time to use the hospital own data, the local area data, for the central data processing. So standard datasets approach at the national level began at that time. The key success factors of the 7 years of research, universal health coverage policy environment, because we want to push to achieve, and the research was the approach to gain the knowledge and confidence. So we have the member of the team of the research, people who are expert in healthcare financing, in the cost accounting, in the medical coders, medical informatics, and the auditor. It's the team that work together in their several areas of expertise. After we can establish DRG version 2 for the universal coverage policy in Thailand. So since the first version before universal coverage, and at the time of the universal coverage, and after universal coverage, because we implement universal coverage policy, and the teaching hospital must come in. Teaching hospital cannot opt out from the overall system, because the most complex cases need to be referred to the teaching hospital. So at the time, we look for the DRG that is that can explain better explain most complex situation. So we change the DRG concept from the HICFA DRG, Healthcare Financing Administration of the US, to the Australian refined DRG, which address the severity level. So then after that, we continue updating the version of DRG, version 4, version 5, and version 6. Version 6 released in 1917. So almost about 5 years in between the versions. And the base rate of the DRG, base rate is the most important signal that sent to the hospital. It's the communication between insurers and the hospital. So insurers protect themselves from loss by not paying hospital over the budget. So at the beginning of the our research on DRG, we were criticized that if we use the DRG as the US approach, if we look at the literature, it's a balloon effect. If we press the balloon at this side and it will bulge, become bigger at the other side, so it cannot successfully control the overall budget. When we look at Australia, how Australia implement DRG, they use the global budget to contain the cost. So it's better control because of the available budget. So with the global budget, the hospital will get proportionately either lower or higher according to the submitted sum DRG at the account, like a monthly account. Sum of the payment, it's according to the available budget and the divided by the some relative rate, and it's it can be lower if the submission of the RW is bigger, or it is the payment is higher if the sum RW is smaller. So the submission period, the available budget can be set monthly, quarterly, or annually, but it's not practical for the annually because the cash flow is important. So the research on DRG when the data collection, we collect the data of all the patients, so it's not focusing on any scheme, but after the universal coverage, even though the universal coverage law in Thailand say that after the universal coverage law, all the schemes should be managed under the National Health Security Office, but this was not possible. We still stay with the 3 schemes for the universal coverage in Thailand. Universal coverage since 2001 cover the majority of the Thai population, 48 million population, and the payment of the UC scheme, we use capitation, and we use also the DRG and with global budget for inpatient care. Social Security scheme since 1990, they use the inclusive capitation, capitation for outpatient and inpatient, and the civil servants medical benefit scheme cover the least proportion, 6 million. They use the fee-for-service for outpatient and use DRG, the latest of the 3 schemes. Universal coverage, capitation, and DRG. So the available budget per capita is about 3,000 per year, and Social Security scheme that use the capitation and the additional payment for the additional payment for DRG relative rate 2 and higher than 2. They spend budget around 3,000 per capita. And civil servants medical benefit scheme, they spend per capita about 12,000 a year. But it's the population pyramid, population structure that covered by the 3 schemes, they are not the same. The universal coverage cover the whole population, but a little bit bulging in the working age, because the working age was covered, the working age covered by the Social Security scheme. The civil servants medical benefit scheme, that they cover the civil servants of the working age, their dependents, that means the son or daughters under 18 years of age, and the elderly, and the civil servants scheme also covered their pension, their retired population. So the average of the population here is older than the other scheme. The payment of the 3 schemes, universal coverage scheme apply the differential base rates for the first few years, because it can be a shock to the system, because if we pay by DRG relative rate, we are managing to the mean. That means we you see a lot of loser and a lot of gainer. Gainer, they make no noise, but loser, they make a lot of noise. Then the differential base rates was practiced in the first few years to reduce this shock. That means the teaching hospital may have a base rate higher than the smaller hospital or the community hospital. Then after that, they apply the single base rate with global budget to control the overcost, and the fixed base rate for the referral cases to the other region. This is to ensure that the referral case will be accepted. For Social Security scheme, they use inclusive capitation for both outpatient and inpatients, so that the after DRG had been used for the universal coverage, the Social Security scheme followed to pay for the DRG, that is the severe DRG relative rate and over than 2 with the fixed base rate. Civil servants medical benefit scheme still use fee-for-service for outpatient care, and the differential base rates for hospital groups by the hospital group. The claim processing, the National Health Security Office manage the claims process in-house, and they use their own groupers to calculate the payment for the universal coverage scheme. And the Central Office of Health Information, or CHI, which is the subunit under the Health System Research Institute, handle the claims for the other 2 schemes. And the CHI advise the CSNDS or the SSS to make the payment to the hospital accordingly. So this is the independent organization. The audit, since the start of the research on DRG, we are already aware of the necessity of having the auditor system. So the DRG payment system enforce the systematic auditing standard. So the standard must be set, and the standard guideline for audit has been developed within these 20 years of our experience. In the audit, it should stay with the standard process, and it should be transparent, because it's the process of taking back the money that have already paid to the hospital, because we found that it's upcoding. DRG classifications and the standard codings, it's important. It's the important process of the coding standard, and the coding by the primary coding of the diagnosis and procedures, and the secondary coding of the DRG, of mapping DRG. So these are the process that have to be clear. The process have to be accurate, and the legal action of the governance of the auditing, maximum transparency of the auditor, since it's labor intensive and it's related to the upcoding or the correct coding and taking back the money. So qualified, certified auditor has this process has been set up, and the three schemes may use the same auditor, but they have their own system of managing how to take the money back or how to handle with the upcoding. For the elements of budget that allocate by DRG, since the Social Security scheme, they spend for inclusive outpatient and inpatient expenditure, but pay extra for the relative rate 2 and higher. So the fraction of payment according to DRG is this portion is not very high. But for the universal coverage, since the recognition of DRG, which related to cost, and the refinement of DRG, of the later version of DRG. As I said, the DRG version 3 that we changed to the logic of Australian refined DRG, which had the severity level. So that's what's also the checkup of the system of the according to the allocation of the budget, bigger and bigger proportion of UC budget spent for the DRG. And this is the political economy between member of the level of hospital that provide care for the different scheme for the. So this is a example of the best rate to example one hospital. This is the cost, and this is the best rate of the civil servants medical benefit scheme. And you can see that as the civil servants medical benefit scheme, they implemented DRG about 5 years later than the UC scheme. And the first year they apply the base rate, the own base rate. That's study from the charge data and the relative rate of the hospital. So this hospital can get it this high, but afterwards they have converged to the group hospital group. So the base rate that this hospital get become lower and lower. And for the other two scheme, for the SSS and the UC scheme, And if we compare to the cost, then it's this signal that the hospital has to manage the cost to be more efficient, or whether the government policy of provide the coverage and pay to the hospital on behalf of the patients, and they get enough budget to be comparable with the efficient cost. When we change the DRG version, it's a checking to send the strong signal to the hospital, because once we change keep update the version of DRG, we want to reflect the real cost of the hospital. So the relative rate will be changed, and the other aspect that we achieve is that we can cope with the upcoding of some situation, because hospital learn which coding process get the higher relative rate. So updating the version can reduce the effect of upcoding. And this is an example of a simulation that when we change version 4 to version 5, the relative rate will drop about 13%, 14% of the patients of CSMBS, and drop about 11%, 12% for the patients of the SSS. And this will impact on the how much we have to pay. If the hospital only look at the drop of the relative rate, it's a threatening signal. It's a threatening condition. So the study of the CHI, Central Office for Health Information, that they contract, they advisor, the payment advisors to the CSMBS and the SSS. The number of the case of the civil servants medical benefit scheme, it's rather stable or somewhat lower. But the change of the using DRG, changing from version 4 to version 5, as I said, the drop of the relative rate, and but the CSMBS not implement the global budget, so the base rate will be higher if the drop of the relative rates. So this is according to the available budget, or the expected increase of budget, and calculation of the base rates. So the base rate calculation of the hospital group, the experience of CSMBS, since the start of the DRG of the civil servants medical benefit, we start with the DRG version 3 that use individual base rate. And when start version 4, so the group we practice in the CS/MBS, they classify base rate to converge the base rates to the hospital to become the hospital group, as example of one hospital that I showed in the earlier slides. So come with the experience of the recent year. Since we launched DRG version 6 in 2017, so the implementation of the DRG version 6 was the first time that Thailand used 3 DRG versions for the 3 schemes. The UC schemes still stay with the version 5 CS/MBS, implement DRG version 6.3. The Social Security use the version 6.2. So this is the situation that we observe. Since the change of the DRG has the effect on the many stakeholders, so the public information related to DRG must be transparent and published in the Royal Gazette government document to be public, to inform public about the change. So this is the transparency process and the multiple communication process to get acceptance of the new payment or new rules or new DRGs. So DRG should, every country should set the system of payment according to DRG to be fair to all stakeholders, comparable to cost, to have the system of transparent, have the consensus approach, and try to keep evidence so that evidence base will be contestable if any independent body want to review the process, and should be impartial, should be neutral, especially for the audit or the claim process, and should keep it updated to the situation. And don't expect DRG to solve everything, to solve every problem of a payment method. And don't stay with the payment of a few disease or disease group or the procedures, because it will not be universal coverage. And don't adhere to the clinical pathway or the standard approach of treating certain disease, because That's the idealistic, but in the real situation, we are dealing with variations, and DRG is try to cope with the variations with the comprehensive approach. So the low and middle income countries learned from the experience in Thailand that because of the basic ground of DRG development based on clinical data and resource use data, wherever we have these clinical data and resource use data for at the individual level and in the electronic format, which is the situations that most of the countries have these, but never use at the central level at the to calculate for the calibration. We can use this data for calibration. We may not have a very good data on cost, but at least we have cost data at the macro level that can be the guideline for the base rates setting, and focus on the team of expertise that working persistently in the for the learning curve until the learning curve achieved, and set up the transparent system for the sustainable DRG development. That's the what I want to present in this model 2. And the next model will be on the mechanism of DRG development, which is focusing on the development of grouper, which is an important tool of the DRG. So discussions, questions.
So, okay, thank you so much, Professor Subasit. So I have seen few questions in the chat box. However, the time is at the end, but maybe I will pick some questions for you to answer. So the first is from Mr. Reem Hafez. So he asked, whose responsibility was it to develop and maintain different versions of grouper in Thailand, the MOH or the NHSO? Could you talk a bit about why that decision was made? Dr. Subasit.
Whose responsibility to develop the
Yes.
In my slides on the insurance model, I would prefer to the D, which is the regulators, because it's the balance as the history in Thailand, as I said, it's the research base, and the from version 1 to version 6, it's also the researchers driven, because sometimes it may not be initiative of the funders to update it, but as the researchers, as I said that we should keep on updating the revision. One way is to cope with the new technology. The other way to cope with the upcoding. So this is the in the element D that the regulators or the independent body or the researchers to make the insurance model, not just leave it to the third party, three parties.
Okay, thank you so much, Dr. Supasit. So maybe another questions. Can you clarify further about universal coverage scheme? The slide mentioned both about using DRG and global budget. So, Mr. Edward, wondering how does it works out? So maybe you can point out more about this. Yes, doctor.
As as I said, when we first known about the DRG in the US, because of the ballooning effect, when we press this side, the cost will bounce on the other side. But once we apply the global budget, we don't let the size to be expanded. It will be kept into control. The global budget, it's the sometimes I said it's a hard control measure that we have this amount of budget. So it's according to the submitted relative rate to how many patients receive, how severe they are. So we have only the cake at this site. So if more number come to the party, so the slice of the cake, the size of the cake will be each will get smaller size. So that's the meaning of the global budget and the DRG.
I see. So thank you so much, Dr. Supasit. So I think here's the last questions. Would you please explain on how the systematic auditing standard, including process and the tools, established or developed, who were involved in the process and who provide certification for the auditors? Thank you.
The experience, our experience in Thailand, as I said, we start from research, and we don't. Then we have to learn and design, which is fit with our system. So the what rather be the knowledge from our experience that this can be the governance of the funder. The funder should set the rules, but the rules written by the experts or the auditor, which is the independent auditor. They are dependent, they are employed for their academic activities. So auditors are independent, but funder make use of independent auditor. Funder can set the certification, but they have to make use of the independent experts or capable experts to do that.
I see. Okay. Thank you, Dr. Supasit. So here is the last questions from Muhammad Khairul. So what is your opinion on the coming ICD 11? Would it expedite the development of DRG compared to the current ICD 10 or 9? So he asked about the transitions, maybe from ICD 10 right now to ICD 11.
We still debate. For the smooth transition is that since Dr. Bunchai may discuss this better, but what we discuss is that if we have good documentation that translates the clinical language, that means the clinicians, their own language, into the coding. Don't force the clinicians to learn coding, but clinicians document the clinical language, and it's the platform of the informatics that turn the clinical language into the coding. Once we have coding that can be mapped crosswalk from 10 to whatever.
Okay.
I can add this a little bit. I think I'm learning the DRG with all of you too. I learning from Dr. Supasit, is my mentor for learning about the health financing. Even I do on the health information or health data, but I learning over the year. So in my opinion, we have to understand that the ICD is a precursor of the DRG grouping. And the clinical data or clinical language is the precursor of the ICD. We group the disease from what clinician describe into group in the ICD, which is the classification. So you can see that there is the bottom is the clinical language. What is what the diagnosis in terms of the physician or the clinical perceive, and then the coder will group it into the ICD, and the ICD is used by the grouper to group as the diagnosis related group to come up with some number about the same resource that used in different diseases. Implement ICD, it takes time, and people have to learn a lot of the coder have to learn how to understand the clinical language into group into the ICD. In case of Thailand, we enforce the use the ICD before maybe 4 or 5 years before the DRG has been developed. So there is a mechanism, a process to build the coders. So at the time that we have developed the DRG, then we have some ICD to come to get into the grouper. So the point is that to get to the ICD coding, it a long process also. Now come to the ICD 11 and ICD 10. The question is that will the ICD 11 expedite the DRG instead of the using the ICD 10 or ICD 9? To my knowledge, no countries in this in this world are using ICD-11 in their grouper, which means that in the DRG communities or research, they also looking at these two. This how they gonna get the group which is will be input into the the group of disease input into the their grouper or their classification to the DRG. I'm not personally I'm not I think it's not easy and it's not expedite at all. It's the same if you just clean slate and trying to get into the ICD-11 and then develop the DRG yourself, then you have to learn from the other country, and no country in the world right now use ICD-11. That will be a very tough task. Not just to implement the ICD-11 into the healthcare system. And I think the DRG community, the case mix community, they are looking into this issue too. So the question is that, is it the easy transition from ICD-10 to 11? This is in terms of coding. For the country that use ICD-10 and would like to migrate, transition to ICD-11, the nature of the ICD-10 and 11 has a big change from the ICD-10. So my personal opinion is that it takes quite effort to learn the ICD-11 because of they have two parts. One part is the traditional ICD classification. Another part is the ontology. They call the foundation, the ICD-11 foundation. So you have to learn 11 from the start and then compare to the 10 and transition from 10 to 11. That's another process that we have to learn. For Thailand, we still we looking at the ICD-11 also. But right now we are not enforced the hospital to change to ICD-10 to ICD-11 because of many reasons. One reason is the DRG using ICD-10, and another is they have to learn. Learn the ICD-11. That is my personal opinion. We can discuss about the ICD and terminology and classification for many hours, and it's a big issue globally right now. Thank you.
Dr. Kunchai, maybe the last question. Do you know that the mapping from ICD-10 to ICD-11?
I think the WHO will provide those, to my knowledge. At least for the statistics, every country have to report the table of the mortality and morbidity tables. So that they will definitely, to my knowledge, that they will have the crosswalk between ICD-10 to ICD-11.
Okay.
And at the same time for ICD-11 to ICD-10. When we talk about mapping in the terminology, the mapping will usually not two-way. We have only one-way mapping. So you need to have the target code and the source code from source to target. It's no way for the two-way mapping.
Okay,
That's a basic. Thank you.
Okay, thank you so much, Professor Subhasit and Dr. Kunchai. I think we now reach an end of this webinar tonight. However, you may join we have the third DRG webinar on the May 25th. So you may join So we can see each other again on the May 25th. And to launch for other webinars of AHIN, so we have open a webinar series on May 6th, and on May 9th, we have health data governance principles. So hope you enjoy all the webinars. So I think, thank you so much for your participation.
Thank you.
Thank you. Thank you very much.
See you next time.